Hi everyone, my name is Jordan Loveridge and I'm the Director of South Coast Dizzy Clinic and one of the vestibular physiotherapists here. So I've been invited today to talk about vestibular physiotherapy, which includes the assessment and management of vertigo and dizziness. So I've been fortunate enough to work in this space for quite a while now, being able to work closely alongside many of the local nose and throat specialists, neurologists and GPs. So I want to start by talking about the difference between central and peripheral vertigo. So central vertigo is caused by an issue within the brain, typically. So things like tumors or growths, which may reproduce some vertigo symptoms. The other one is peripheral, which is our inner ear, basically. So think of this as being a cause outside of the brain. So we're talking about our vestibular system, the nerve coming in, anything outside the brain which may be causing symptoms of dizziness, vertigo, balance-related conditions. And these are the conditions that we typically see more of. We can help manage some of these symptoms from a central cause, but by far the most common is coming from a peripheral cause. So, a quick overview of the anatomy. So we have 5 sensory organs. So we have 3 semicircular canals, and they're essentially now 3 dimensions. So think of these like spirit levels. So every time you move your head, turn side to side, the fluid within those canals are trying to level out, and that sends a message back up to the brain and tells us what's going on. It's incredibly sensitive, and it's quite an amazing system. It's a very small system. So if you look at your thumbnail, it's probably about the size of your thumbnail, and it sits on either side, left and right sides of our inner ear. It's quite an amazing system, which we rely on a day-to-day basis. So they're the semicircular canals, and then we have our otolith organs, which are in green box here. So we have our utricle and our saccule. So these are our accelerometers. So within some of these structures, we have hair cells, and these are our motion sensors. So they're essentially transforming that motion into a message that goes back up to the brain. As I said, it's a very clever system. It's a sensory input about head velocity, these semicircular canals. So they're telling us how fast our head is moving and in what direction. Interestingly, they closely align with the direction of the pull direction of some of our eye muscles, and they're coplanar, which means the left and right sides are coupled. They work together. So let's say my right side is working, my left side is also working to give me that similar message. So it's a very reliable and accurate system. So we're going to talk about BPPV first. So it's better known as positional vertigo. Some people just call it the crystals, and it's the single most common cause of dizziness in adults. And it accounts for roughly a third, so roughly 30% of all dizziness in adults over the age of 65 years old. And the prevalence increases with age. So as we all get older, our likelihood of getting BPPV increases as well. So it has these hardened otoconia or calcium carbonate crystals. Again, most people just call them crystals, which dislodge from our utricle, that accelerometer part, and fall into one of our or sometimes multiple of our semicircular canals. So now we've got, if we want to use that analogy, we've got something fall into some debris into our spirit levels, which means our spirit levels isn't giving us an accurate and reliable message anymore. So essentially it's disrupting the function of our semicircular canals. So why do we get it? So age comes into it, like I said. So that's one of the reasons potentially for developing BPPV. Trauma, so anyone under the age of 50, this is the most common cause of BPPV. So things like car accidents, head trauma, brain-related injuries, heavy football tackles, concussions, for example. Anyone who may experience ongoing dizziness or vertigo symptoms should get investigated. Inner ear disease, so think vestibular neuritis, labyrinthitis, anything that's caused some disruption to that inner ear. Osteoporosis increases our risk of BPPV, and also surgery. So when we're talking about surgery, we're talking about some of these surgeries which might mean that we have to be in a sustained position for an extended period of time, and also some ear-related surgeries. So again, when we're thinking of BPPV, it is a mechanical issue. So think of a marble and a set of pipes. Every time I pick up that set of pipes, the marble will fall, and that will give me symptoms. Okay, so if my head is completely still watching TV, for example, and I get a sudden onset of spinning or dizziness or vertigo, my head hasn't moved. So it's potentially not BPPV causing me these symptoms. It could be something else which need further testing and investigation. So the classic presentation of BPPV, we're going to get a vertigo attack, so that spinning, unsteadiness sense when we're laying down in bed, rolling over in bed, looking up, or bending forwards. So it's typically a spinning sense or a moving sense, and most of the time it's less than 60 seconds. There are always exceptions. So there is a certain type, which we'll talk about in a second, which is greater than 60 seconds, but most of the time it's less than 60 seconds. We're getting that vertigo symptom, so that self or environment moving, a general sense of unsteadiness, and unfortunately we get the nausea, the sweating, and the heart starts to beat quite quickly as well. So the most common canal which is affected with BPPV is our posterior canal, which is the canal that wraps around the back here. So you'll see it's one of the largest ones here, wraps around the back. This is called our posterior canal. And we're going to say, depending on what you read, roughly 90% of people who suffer from BPPV will have this canal affected. The next most common is our horizontal canal or our lateral canal, and that sits relatively horizontal to ground. And that's give or take about 10% of people. And then we have our anterior canal, which is by far the least common. So we know that unfortunately there is a chance of getting BPPV back again at some point in your life, and that's about a 50% recurrence rate. And then we're also talking about the difference between a canalithiasis versus a capsulolithiasis. So a canalithiasis, which is when the crystals are within the canal part of the semicircular canal, and a capulo is when it's stuck up the end. So with a canal, which is by far the most common, is going to be your symptoms will stop within 60 seconds. And then the capulo, which is by far less common, is your symptoms will go greater than 60 seconds. So basically you won't stop spinning when you lay down. So how do we test it? So to test the posterior canal, we do what's called the Dixhall-Park assessment, which is by far the gold standard assessment for assessing the posterior canal. I emphasize this is only for the posterior canal. So what we do with this is we lay the patient down, their head comes slightly off the edge of the bed and turn to the side slightly. And what we're doing is looking at their eyes to see if they have what's called a nystagmus, or a flick in their eyes, an involuntary eye movement, which tells us, do they have BPPV? And if they do, which canal is affected by the direction that their eyes are moving or beating. So while someone's in this position and they are suffering from BPPV, it can be quite symptomatic or dizzy. So it's important to be aware that they may be symptomatic in this position. So we're lucky enough at South Coast Dizzy Clinic to use infrared goggles, or we use Vesticam goggles, which mean that the patient is put in complete darkness, so their vision's denied, with an infrared camera looking at their eyeball. So this allows us to assess for BPPV and other vestibular-related conditions with much greater accuracy, so our diagnosis is much stronger. We can also then send off this file of the video of the nystagmus to some of the specialists if we're at all worried about them. So again, the patient will wear these goggles whilst we're assessing for BPPV. They won't be able to see a thing, but I'll still be able to see what those eyes are doing, meaning I have greater accuracy. So what are we looking for? So this is what the eye will look like if someone is suffering from BPPV. So we're going to lay this patient down, and we'll see the eyes will start to bounce. So I'll talk you through the video. So we're going to lay the patient down now, and the eyes should stay still, but you'll see the eyes start to bounce up and down and off to the side. So that's telling us that this person is suffering from BPPV, and it is in the posterior canal. Now, this person is feeling a dizzy or vertigo sense. They may not necessarily feel their eyes moving, but that's our job to look at the eyes and see what's happening.
Here's another quick video. So again, we're going to lay the person down and you'll see the eyes start bouncing around. So that's what we call a nystagmus. and that's what we're looking for when we lay the patient down. So there's some really good research, a lot of research, and sort of gold standard research on BPPV and how it's assessed. So the Dixon-Pike has a strong recommendation for the assessment of posterior canal BPPV. And so recommendations against imaging. That's unless we're not certain it is BPPV though. If we're not sure, then sure, imaging's fine. Formal vestibular testing. So that's the one with electrodes all over you, maybe some water in your ears, for example. Look, if it's BPPV, we know what it is, unless there's obviously other signs that we're concerned about. Then we don't need to do further testing because we know what it is. But we'll always communicate with the specialist who's referred you in or your GP to make sure that there's nothing else that needs to be investigated. And the other one is the use of regular vestibular suppressants, which is medications. Now, that's posterior canal, the one we just spoke about before. That's 90% of people. The next most common is the 10%er. So that's the horizontal canal. So typically, this is when some people might experience a spinning sense on both sides when they roll over in bed. They might get it when they bend forwards or when they look up. Now, how do we assess it? So we lay the patient down on the bed, goggles on again, and we're going to turn the head as far as we can to the left, come back to the middle as far as we can to the right. Now, it's a different nystagmus than what we saw before. It can be quite violent, quite aggressive. It can be subtle. Again, nystagmus comes in all shapes and sizes. But again, you're going to experience that spinning sense, that intense dizziness, vertigo that we've spoken about. I think it's really important to note here that these are quite complex because they can be in different parts of the horizontal canal. So unless you're comfortable with assessing and treating horizontal canals, I would suggest and encourage you to refer on. And you're always welcome to contact me if you have any questions, and I can potentially help you guide through an assessment if needs be in the GP clinic. So this is what it looks like. So we're going to lay the person down, and you'll see the eyes start bouncing around horizontally, so side to side. The other ones are beating up and over. These are side to side. Again, you can't miss it. It's quite aggressive, but again, it settles down within the 60 seconds. There it goes, slows right down. So that's BPPV in a nutshell. So we're moving on to the next one, which was what we're going to call a vestibular neuritis. So again, very common cause of sudden onset of vertigo. What it's caused by is an acute inflammation of the vestibular nerve, or our 8th cranial nerve, and it's usually a viral infection, and typically it's that herpes simplex virus. Most people will present with a severe sudden onset of vertigo, lasting somewhere between 2 to 4 days. Not always, but sometimes people also report flu-like symptoms and a general sense of feeling unwell. But typically, these people are extremely dizzy, very unsteady, quite nauseous. It's quite a memorable period for this patient because they feel really, really, really unwell. Most people will become relatively symptom-free after 6 weeks, but in saying that, about 40% will experience ongoing instability, and their VOR gain, which is their ability for their eyes to stabilize, may not return to normal. That's till we come into it, which I'll explain later, and our job is to help rehabilitate that system. The next one, which some people may have heard of, which is called a labyrinthitis. So think of that as a very similar presentation to a vestibular neuritis, the one we just spoke about, but now we're also experiencing a sudden onset of hearing loss. So this is very important that if you experience this, you call your doctor straight away to get seen to, because we need to act on this relatively quickly, okay? And I would even encourage you to present to the emergency department if you experience sudden onset of hearing loss. The dizziness and vertigo symptoms are exactly the same as a vestibular neuritis. Sudden onset, severe dizziness, vertigo with nausea. So you've had that awful event, and now the aftermath, if you will, is called a vestibular hypofunction. And if it's happened on one side, that's called a unilateral vestibular hypofunction. So this can also be caused by things like age can come into it, things like a history of Meniere's, anything that has caused a damage or a disruption to your inner ear system may cause a deficit, left versus right, which creates an asymmetry, which will then give us a sense of unsteadiness, wooziness, giddiness. Some people describe it like a drunkenness or a tipsiness. Typically, people don't like busy environments. They can feel quite overwhelmed in places like shopping centres, markets. They often describe a veering sense or a falling sense. They might bump into the doorway or bump into the kitchen bench on a regular basis. They can experience dizziness or unsteadiness with rapid or unexpected head movement. So this is what we're looking for on the assessments. So we're not going to see BPPV. There's going to be no central signs. Our head impulse test will be positive. There'll be a positive eye lag. They're not going to like the Romberg's eyes closed balance test, and they may turn on that Untenberg's marching test. So we performed the head impulse test, also known as the HITS test. So what this is we're doing a rapid and a little small movement, small amplitude head movement, which is trying to catch that patient's eyes off guard to see if their eyes can stabilize on the point. So this is what we're expecting to see. So we're going to turn the head side to side and a quick, and you'll see that eye lag. Eye lag. So that one's normal. That one's an eye lag. So the eyes aren't able to keep up with that random and sudden head movement. So we call that an eye lag or a positive head impulse test. So how do we help these people? We do what's called vestibular rehabilitation. And this is trying to improve that impairment of the vestibular system or that vestibular hypofunction. It includes gaze stabilization or VOR adaptation exercises, gaze shifting exercises, and also some habituation or desensitization exercises. Very good evidence, level 1, strong recommendations for the use of vestibular rehab for acute, subacute, and chronic unilateral vestibular hypofunction. So very good evidence to support this approach in managing these symptoms. So move on to Meniere's disease, which a lot of people have no doubt heard about. It is quite a rare condition though. So what we're expecting to see here is 2 or more spontaneous attacks of vertigo lasting somewhere from 20 minutes to 12 hours. You may get some low to mid frequency hearing loss, and you may have some fluctuations in ear symptoms. So we're looking at hearing loss, tinnitus, or a fullness in the affected ear. And obviously there's nothing else causing it. Probable Meniere's now is from 20 minutes to 24 hours, and we've got that fluctuations in hearing loss, tinnitus, and ear fullness. Again, nothing else is the cause. Vestibular migraine. So these are really important to talk about. It's a very common cause of episodic vertigo, both in adults and children. So quite simply, it's a type of migraine where you experience dizziness, vertigo, and or imbalance, which lasts minutes to days. Now, interestingly, you don't actually have to have a headache. You just have to have associated migraine features and the dizziness, which we'll explain. Quite common in females in their late 30s to early 40s. Now, it can involve anyone, but again, that's probably the more common presentation. How do we fix it? So vestibular rehab is quite important. So those things we spoke about before. We talk about lifestyle changes, so good sleep, good hydration, good exercise, good diet, some anxiety and stress management symptoms, approaches are important. Medications, so working with your specialist or GP to try and work with some medications to get a hold of the migraines, and also trigger identification. So, is it coffee? Is it chocolate? Who knows? There's so many different types of triggers out there. So trying to work out, is there something that triggers my migraine and my dizziness? And obviously then stopping that. So this is the diagnostic criteria. So it's at least 5 episodes which fulfill B or C, C or D. So essentially we need a history of or a past history of migraines with or without aura. We need to have vestibular symptoms of moderate to severe intensity lasting, which is important, 5 minutes to 72 hours. So it's not seconds like the crystals. This is 5 minutes to 72 hours. And at least 50% of the episodes are associated with one of the following 3 migraine features. So we're looking at a headache with one side location, pulsating, moderate to severe intensity, and aggravated by routine physical activity. Also some light sensitivity or noise sensitivity, and also that visual aura sense. So moving on to what we're going to call triple PD, or persistent postural perceptual dizziness. So think of this almost as a chronic dizziness. So it's defined as a persistent, non-spinning dizziness and unsteadiness, which has been there for greater than 3 months. You typically, not always, but you typically feel worse when you're upright, exposed to movement or complex visual stimuli. And again, not always, but typically follows an acute or episodic vestibular or balance problem. So it's one of the most common causes of chronic vestibular conditions. It can be any age, but typically in your 40 to 50 age group, roughly. And unfortunately, women are more likely to experience this. So around 65 to 70% of these people are female. We do see a link with things like anxiety and mood disorders are quite prominent. So about 2/3 of patients with triple PD may be suffering from something like anxiety and stress. And about 1/3 of the cases were directly involved an episode of anxiety with the absence of any vestibular disorder. So you don't have to have a dizzy spell to be experiencing the aftermath or triple PD. So this is how I describe triple PD. So instead of reverting back to normal balance processing after an event, a maladaptive cycle can develop, which causes these triple PD symptoms. Simply, a person with triple PD does not switch out of crisis mode and remains on red alert. So they're always ready to pounce, so to speak. They're always looking for that next sense of unsteadiness and ready to pounce. So the brain becomes hypervigilant and hypersensitive to the difference between anticipated and actual motion. So how do we fix it? Look, sometimes antidepressant meds, but again, we're going to talk to our GP or specialist about this. Cognitive behavioral therapy, or CBT, has a lot of nice research behind it. And then we come into play, so we're doing vestibular and balance rehab therapy. So habituation, desensitization, vestibular exercises, trying to get that balance center to improve in its function, but also not be so sensitive to motion. So again, this is what we touched on before. So about 1/3, give or take, of people with triple PD are coming from things like anxiety, vestibular symptoms down here, and then some neurological conditions over here. So you don't have to have had that significant vertigo attack, for example, to then have triple PD. So vestibular physio. It's important to get your BPPV or the crystals and other vestibular related conditions assessed by an experienced and qualified health professional. It's very important that they know what they're doing so they can make an accurate diagnosis and make sure you're in safe hands. Most types of dizziness and vertigo related conditions are treatable with evidence-based treatment and safe. They're very safe maneuvers and treatments. Important here, I always ask this question, there are no joint manipulations, cracks will ever be performed at South Coast Dizzy Clinic, and I emphasize that. So thanks everyone for your time today. If you have any questions, please don't hesitate to jump on our website, email me, email our admin. Currently we have 4 locations in the Illawarra, Meniere, Milton and Southern Highlands regions. So I really hope you found that beneficial today. Again, please don't hesitate to reach out to my email address to ask any specific questions you may have, And we also have some more information on our website. So again, please don't hesitate to have a look on our website. Thanks again for your time, everyone.